So to talk about malignant tumors of the skull base, I just wanted to show you this graphic, which is a one slide snapshot of my practice over the past close to 30 years. And what the blue outline shows are the malignancies. And you can see this, how they're skewed towards the anterior and middle skull base, primarily anterior, where very few malignancies occur in the posterior skull base, where predominantly we see benign disease. And to put some context on it, this is a talk is about 650 or so malignancies, and that I've surgically managed. What you can see, the majorities are clearly in adults that make up the large majority of what we see, with only about 44 that we've operated on in children. But you can see the different distribution of pathologies. In adults, as you can imagine, the primary malignancy is usually based in the sinonasal region and is epithelial in the cell of origin. Whereas in children, the majority of tumors that we see are mesenchymal tumors, specifically the sarcomas. The distribution of these tumors also varies between adults and children. In adults, the majority of the malignancies are in the anterior skull base, and the majority of those tumors are of epithelial origin. And as you go more posteriorly in the cranial base in adults, the relative percentage of sarcoma increases the further back in the skull base that you proceed. Much different than in children, where the majority of tumors we see are in the middle skull base, and the majority of those are sarcomatous. In adults in the anterior skull base, the majority of tumors we see, as I mentioned, are of sinonasal origin, and the big players there are squamous cell carcinoma, olfactory neuroblastoma, adenoid cystic carcinoma, adenocarcinoma, and sinonasal undifferentiated sarcoma. In the middle skull base, the majority are sarcoma, but the epithelial tumors that reach there, the squamous cell carcinomas and adenoid cystic carcinomas, are generally either direct posterolateral extensions from the sinonasal cavity or perineural extension of sinonasal diseases into the medial middle fossa. The majority of tumors in the posterior skull base are of sarcoma origin, and the majority of those that we see are the chondroid-based tumors, chondrosarcoma, and chordomas. Those slides detailed over 35 different tumor pathologies, over 20 varieties of sarcoma, and over 15 non-sarcoma pathologies. So it's clear that no single person has that compendium of knowledge to know how to best manage each individual person with individual pathologies, individual locations. So we always discuss these patients comprehensively in our multidisciplinary tumor conference. You can see the participants in those conferences on the right. It's really important, and even more important as we become smarter doctors, that we discuss these patients ahead of time to know where surgery fits in the overall treatment plan. This is why this is so important. This is a very short case example of a patient that I saw who was neurologically deteriorating. As you can see in the bottom left panel, there is an intracranial hemorrhage associated with this large sinonasal tumor. He was quite sick with a lot of intracranial hypertension. So I didn't want to do a long operation. So I definitely just went in, took out the intracranial disease, and left the sinonasal disease in place. And if you look at the two top panels, that's what his scan looked like after his operation. He did very well from the surgery, and we went ahead and treated him with chemotherapy. And what you can see, after 4 courses of etoposide and cisplatin, he's definitely had a reduction in the size of the tumor. And in fact, the CAT scan on the right shows some reformation of his nasal bones. I took him back to the operating room, and we completed the resection and followed that with radiation therapy. He's still free of disease now, I believe is almost 12 years later. But the important part of this story is his pathology from his second operation. After the chemotherapy, there was not a single viable tumor cell identified, really highlighting the importance of the appropriate chemotherapy in this disease. The patient like this is what led to this study that we did here which has been published recently, and I would recommend it. We looked at the sinonasal undifferentiated carcinoma, really the most malignant of the sinonasal primary tumors. And we treated these patients with induction chemotherapy and followed that either with concurrent chemoradiation or surgery, depending on the response to the induction chemotherapy. This is how we stratified those patients. And what we found in the overall group, the 5-year disease-specific survival and the 5-year overall survival were very similar at 59 and 56%. But we saw a real separation in survival between those patients who responded to the induction chemotherapy and those that did not. So there's a significant difference in survival in the patients who responded to chemotherapy. Taking that, the next step, we looked at what we did to those patients after the induction chemotherapy. It also showed a separation in outcome favoring the chemoradiation therapy. So to say it another way is the patients who were treated without surgery actually did better than those that were treated with surgery. When we put that together in one slide, the top panel of overall survival and disease-specific survival are those who responded, and the bottom panel is those who did not respond. So in the induction responders who were treated with chemoradiation therapy following that response, there's a marked improvement in survival compared to those patients who were treated by surgery and radiation. Now that's different in those who did not respond. Those graphs flip in the non-responders. So in those patients who did not respond to induction chemotherapy, the survival advantage was given by surgery and chemoradiation. What we think is happening here is that we are, by proceeding with chemoradiation therapy following the induction, we are diminishing the incidence of local regional recurrence and distant metastasis, and thus favoring survival in those patients. Because when you follow the induction with surgery, there's a significant downtime where the patient is not being treated following his operation. And we think that's where the window of opportunity for the disease to spread occurs. So that study, I think, was important for us. It helped change how we think about some tumors. We found that 2/3 of patients with sinonasal undifferentiated carcinoma responded to the induction. Those that had the response did better overall. And those that responded and were treated with chemoradiation right afterward had better disease control, better organ preservation, and improved survival. But we have to identify the non-responders because those patients were best treated with surgery, followed by chemoradiation. The secondary conclusion of that study, and the reason it's important to us, is that the role of surgery in the care of patients with these malignancies really continues to change. There has to be a continued reevaluation of the timing, the extent, and the goals of surgery. And the neurosurgeon who treats these patients needs to be actively involved and participate in the creation of these novel treatment plans. And as always, patient selection is going to remain critical in determining the optimal surgical approach for these challenging tumors. I want to just move sideways into the concept of craniofacial resection. It's, as you know, the combined transfacial and transcranial resection of sinonasal malignancies. It represented a true paradigm shift in the management outcome for patients with these malignancies. The technique has been in use for over 6 decades, since the articles in the 50s and 60s by Smith and Ketchum. But modern and long-term outcome data has been lacking for many years now. We've done a lot of work on sinonasal malignancies. We've looked a lot at their biology here at MD Anderson. We've looked a lot at the surgical management of them, and we've looked a lot at use of adjuvant therapies in their treatment. Our data, which has been published over the years, and the references are present on the slides, have shown an expected 63% 2-year survival for anterior skull-based malignancies of all pathologies, 81% 2-year, 53% 5-year in lateral skull-based malignancies of all pathologies. When we look more specifically at different pathologies, high-grade sarcomas, our survivals are 66%, low-grade at 85%. Olfactory neuroblastoma, we just had a paper come out this month, which I have not quoted here, showing a disease-specific survival of 92% at 5 years. but importantly, about 60% at 10 years, because these tumors, their average recurrence interval is 5 to 7 years following their treatment. We still are doing poorly with mucosal melanoma, where we have a disease-free survival of only 18% at 5 years. The writing is very small here, but these are some more recent papers from our institution about adenoid cystic carcinoma, squamous cell carcinoma, osteosarcoma, and infratemporal fossa carcinomas. Important conclusions with there was a difference whether or not you got a complete resection with negative margins versus a complete resection with positive microscopic margins. So we do attempt, especially in the high-grade tumors, to get what's called an R0 or R0 resection with microscopically negative margins. Over the 30 years, things have changed somewhat in our practice, and I don't know why specifically, but we have seen a trend of an increased number of patients with neuroendocrine tumors, such as neuroendocrine carcinoma, sinonasal undifferentiated carcinoma, and olfactory neuroblastoma, as well as patients with melanoma. But we've seen a reduction in patients with adenocarcinoma, squamous cell carcinoma, and the sarcomas. We've also seen a change in how we manage these patients over the years. In the 1990s, the primary surgical approach was a combined open transcranial and transfacial approach. Through the 2000s, we kind of pioneered the transcranial only approach, but with the maturation of endoscopic technology, we started incorporating the endoscope more and more during the 2000s, talking about the transcranial endoscopic combined approach. And as you can see in the 2010s, many of our sinonasal tumors are primarily managed completely endoscopically. These are two papers from our group. The first was published in 2009, which, along with the Italian paper published around the same time, really was a proof of principle that oncologic outcomes in well-selected patients are equivalent between exclusively endoscopic approach and cranioendoscopic approaches or open approaches. This was updated just recently in 2020, again, looking at our purely endoscopic resections compared to our endoscopic assisted resections, and there was no difference in oncologic outcome. Of course, this is with well-selected patients. The endoscopic patients tended to be of lower stage than the open patients. So the question now is no longer endoscopic versus open. The question is the criteria for endoscopic and or open procedures. My colleague, Dr. Raza, who's going to be speaking next, will specifically address this very important topic. The other thing that's changed in the last 30 years is that we've seen an increase in our management of patients with more extensive disease. I think this reflects the maturation of our skull-based approaches and our techniques, so that we began expanding our surgical procedures to encompass more challenging diseases. And in the 2010s, we've seen an increased number of patients that we're operating on in the presence of metastatic disease. And I think this is also an indication of our improving non-surgical therapies for these diseases, both medical and radiotherapeutic. Recently, we published a paper on this data, and what I did is I utilized this classification system for surgical complications. The reference is on the slide, and it's a little bit better than just calling a complication minor or major. It really kind of categorizes them a little more carefully into things that don't require any intervention, or like category 3A, where a spinal drain insertion is a good example, or the elective evacuation of a hematoma or wound revision. And then it goes to higher grades, whereas grade 4 would be the emergent evacuation of an intracranial hematoma. Over the 3 different decades, these are our complications. And in general, what we've been happy to see is that from the first decade to the third decade, there's been a significant reduction in our morbidity associated with these procedures. And when we tried to look at that more carefully, what we identified is that all our complications were statistically less in those patients where we did not use lumbar spinal drainage. Specifically, this complication, the complication of intracranial hypotension, was very significantly reduced in those patients. In fact, it was absent in the patients without a lumbar drain. So based on this data, early on in my practice, we actually stopped using lumbar spinal drains for these procedures. The intracranial hypotension syndrome is, in its most mild form, has some mild postural headache, but it could be so bad that the headache is severe, it's incapacitating. You do a CT scan on these patients, and typically you see a mix of epidural air and fluid, accompanied by a concave appearance of the dura like that. And in its worst form, it could be a tension pneumocephalus with a large epidural blood or fluid collection. And in those cases, it requires surgical intervention. But most patients were managed with fluid hydration, placement of a high volume lumbar spinal epidural patch. And as I said, this complication is uniquely associated with lumbar spinal CSF drainage. Now, you have to keep attention to your data because just because something works doesn't mean it's always going to work. And as we started incorporating endoscopy into our practice, what we saw is that our CSF leak rate increased in those patients who we did not drain. So despite the data from the previous several decades, when we went to a cranioendoscopic and an endoscopic only approach, we did change our management paradigm and reincorporated lumbar spinal drainage into the practice. And since that time have had a much reduced spinal fluid leakage rate with only one patient with the syndrome of intracranial hypotension. Over the years, there have been many traditional relative contraindications to extensive craniofacial surgery for malignancy. We've tried to look at these systematically over the years. We found in this paper that even with patients that have transdural extension, meaning a tumor in the subdural space or in the brain, that with aggressive management, you can achieve a mean overall survival of over 5 years. What we found there, as I've outlined before, microscopically negative margins are critical to maintain that survival advantage. The other interesting thing we found is that it did not matter whether or not you took out the tumor en bloc or if you took it out piecemeal, as long as you got it out with microscopically negative margins. And that has a lot of implications in the endoscopic resection of skull base malignancy. Tumors that start in the anterior sinuses can extend into the middle fossa. There we have an adenoid cystic carcinoma extending into the maxillary division of the trigeminal nerve to the anterolateral cavernous sinus. We have pursued those extensions aggressively, both through direct transfacial approaches and also through endoscopic approaches, because, and we can get far enough back to get into the Gasserian ganglion, as you see in the bottom right. It's important because in our series of patients with adenoid cystic carcinoma, a microscopically margins negative resection imparted a significant survival advantage, 20 years versus 10 years in that patient population. So especially with that disease process, the aggressive pursuit of perineural extension of carcinoma is warranted. Tumors that affect the infratemporal fossa have been classically regarded to have a decreased survival outcome. It requires certainly more extensive multi-compartmental surgery. It requires a very rehearsed multidisciplinary surgical team. But we found that in those patients, we were able to achieve similar survival rates to the anterior skull base, in contradistinction to what's been reported in the past. And when we looked at our very recent paper on infratemporal fossa carcinomas, we found that the disease-specific survival was 32 months with a 5-year disease-specific survival of 55 and a local progression-free survival of almost 70%. So these tumors need to be aggressively pursued, just like the anterior skull base. Whenever you talk about the anterolateral skull base, you got to talk about the internal carotid artery. Of those patients, we had either taken the carotid artery out or the cavernous sinus out, leaving the carotid artery. And when we looked at that data, we thought, oh my goodness, look at that. We take out the artery, the patient has less local recurrence. That was good. But when you look at the real outcome, is that those patients who had the carotid artery resection all died of regional and distant metastatic disease, and one patient had a stroke. So the overall survival for patients not requiring cavernous sinus dissection or internal carotid artery resection was twice that of patients. So currently, we do not advocate surgery for high-grade malignancy when it encases the carotid artery and the cavernous sinus. At times, tumor extends into the orbit, and we have to be involved in orbital resections. This is a deep orbital sarcoma, which we are doing an en bloc resection for. And in this paper, we looked at all our orbitectomies, which are about 180 something. It just got published in Cancer this month. And we see that, again, outcome is distinctly associated with pathology. Our sarcoma patient group actually was the best outcome group in this cohort, whereas typical melanoma has done the most poorly. But you see the survival is over 100 months down there. So I think these patients, even with extensive resections, including the orbital tissues, can have a good survival. And finally, I want to talk about metastases. As I mentioned, we are operating on more patients who have systemic disease. It's the patient with a metastatic leiomyosarcoma who was losing vision in both eyes. At this time, I did a transbasal approach. I think today this would be an endoscopic case. We were able to remove the tumor completely. Her vision returned to normal, and she died 29 months following her surgery of disseminated disease. Very similar to the outcome for brain metastasis, where generally the patients survive for about a year and end up dying of their progressive systemic disease. Now, it's important to note there are exceptions. We had over 2-year survival in 5 of the 7 patients with sarcoma tumors, and a 9-year survival in patients with metastatic follicular thyroid cancer. When you're operating on somebody with metastatic disease, the goal is palliation. And this is the reason we offered those operations. They had an indication which required palliation, such as a progressive optic neuropathy. This is the number of patients who had that problem and our outcome in those patients. So we did well with progressive optic neuropathy. We did okay with progressive proptosis and diplopia. But we didn't do very well with facial weakness, hearing loss. How about doing these operations in the elderly? We know that we're all getting older, but the elderly population is now healthier than in the past and can expect 17 years of life once the age of 65 is reached. What we found is that our elderly patients did just as well oncologically as our young patients. There was no difference. But what we did find is that the patients who were elderly had a 3 times greater systemic complication risk. And the reason for that is clear. Our elderly patients came with the baggage of their years with increased incidence of hypertension, other cardiovascular illnesses, and smoking. So we felt that, age in and of itself is not a contraindication to these kinds of surgeries. You just have to be very, very careful in the perioperative management of these elderly patients in order to maximize their survival outcome. Finally, we looked at the quality of life in these patients to make sure we weren't negatively affecting their ability to live a happy life. And when we looked at these patients, we found that 100% of our patients from a neurologic perspective had a good quality of life. 94% of our patients had a good quality of life from a head and neck standpoint. And then we had independent function in the majority of patients following that resection. And this is important, and why we have people like psychologists and social workers on our multidisciplinary team, is that 30% of patients in our group reported a poor quality of life based on their responses to the general questionnaire. And that really was an indication of problems with dealing with psychosocial changes and having to make adjustments because of their disease and its treatment. It's important to understand that, realize it, and offer the appropriate management to those patients and their caregivers for these problems. So this is a list again of traditional relative contraindications. I think we have surpassed most of them. I think we have problems yet with high-grade malignancies involving the carotid artery, and we have problems with the melanoma histology. Hopefully, as we progress in our knowledge of management of these and of their biology, we'll overcome this last barrier that I see in our way. Thank you very much for your attention, and I'll be around later for any questions that come and for the discussions later on in the afternoon.